Question number 31. What is the investigation which is shown here? And what are the conditions it have to be done? The investigation which is shown is uroflowmetry. It is one of the screening tests in the lower urinary tract obstruction. Any lower urinary tract obstruction. So when it have to be done, any patient who presenting or suspected to have lower urinary obstruction or who presenting with lower urinary tract symptom. It is a screening test. It is not a diagnostic test. It is a screening test. You will tell whether there's a problem in the flow of the urine. As per the flow, you can make some diagnosis. For example, urethral damage, PPH, bladder is not contracting properly. Screening test. Uroflowmetry. Dose of albumin in hepatorenal syndrome. It is 1.5 gram per kg followed by 1 gram per kg. The maximum dose can be up to 100 gram. This for 3 days and subsequently can be given for 14 days. Whichever student who wrote this one or this one, we gave the mark. Whoever wrote 100, also we gave 40 to 60 gram, also we gave. So the correct answer is 1.5 gram per kg. And as per the clinical response, we have to decide on the further dose. Potassium composition in 1 ampule of KCl is, in the word rounds, just turn this ampule, you will come to know the answer. The answer is 20 milliequivalent. Maximum dose that can be given to central line. In the text, you might find a varied answer. Here, what you have to take into consideration, per hour, how many it can be given. In per liter, how many it can be given. Why these two parameters are important? Because it might lead to rebound hyperkalemia, cardiac arrhythmias. In the peripheral line, it can cause thrombophlebitis, whereas we are giving it in the central line. Per hour, up to 40 to 60 milliequivalent can be given. In 1 liter, up to 1 liter of fluid, I'm saying. So here, these two have to be taken into higher order consideration in the treatment part. No absolute answer might work. Here, the answer, at least for this question, you can answer as 40 to 100 milliequivalent. When per hour. This 100 is extremely high range whenever the patient is in severe hypokalemia. This is 100 milliequivalent per liter also, per hour also. But per hour, you can't give 1 liter of fluid. So accordingly, in the infusion set, you have to reduce the quantity. So in absolute terms, if I have to tell 40 to 100 milliequivalent, two parameter which will decide is how much quantity of the fluid you are giving and how much duration you are giving. I have to tell the duration in 1 hour up to 40 to 60 you can give. If the quantity is increased, yes, you can give up to 100 milliequivalent. So this is the bit higher order understanding, because in the text you might get different values in different books. That is why bit detail I gave. Another simple question, possible diagnosis and what might be the treatment given. Background is I told this patient was a case of CKD, not on dialysis or dialysis non-compliance. What you are able to do? Bat wing appearance. Bat wing appearance. This kind of response in the quiz, as we told, this was the X-ray taken in the same day after dialysis. So only after dialysis, these kind of drastic response you will get. Like here you can see the infiltrates are almost 20 to 30% decreased compared to here and here. The patient was in volume overload, dialysis non-compliant, is simple. Treatment dialysis was given, patient improved. Most common cause of hypertension in young age group, it is not renal artery stenosis, it is renal-parenchymal causes. Renal-parenchymal causes include all cause of chronic glomerulonephritis, under which comes IgA nephropathy, any glomerular condition, even minimal change disease is glomerular condition. So that is why nephro terminology are bit, at least the medicine resident, at least half of them might get confused. They treat this chronic glomerulonephritis and IgA nephropathy, MCD, as different entity. No, Chronic glomerulonephritis is nothing but inflammation of the glomeruli. Glomeruli condition can be anything. IgA, MCD, SLE, whatever it is. So chronic glomerular involvement. Glomeruli, where is the glomeruli? Is a renal parenchyma. So this is the most common cause. Second most common cause is the renal artery stenosis. So what is this finding? I'll try to zoom out. The patient detail. Okay, I'm gonna do. Name few complication of the structure marker. The structure marker is the femoral dialysis catheter. And what are the complication? Most common complication is DVT. DVT, catheter infection, which is called as CRBSI, which leads to sepsis, and any kind of arterial injury while inserting. But once the insertion is done, the most common is DVT, femoral hemodialysis catheter. The marker stress. Highest class in this classification. What is this classification? It is Bosniak classification. We use for renal cyst. The highest is the class 4. Why magnesium to be checked in hypokalemia? The answer we expected the student have to mention ROM K channel, renal outer medullary potassium channel. Once magnesium is not there, it will be pouring potassium into the lumen, thereby it will be excreted in the urine. So that is why magnesium deficiency can cause severe hypokalemia because of the ROM K channel not closed. Once it is closed, the potassium won't leak. So whatever the explanation may be, if we found this particular channel name, we give the mark ROMK channel. Okay. So say as contrast-induced nephropathy, what is the time cutoff? This you might encounter in the ward most commonly. The patient might be immediately after the contrast, creatinine might be rising. There are some patients where creatinine might be already high before the contrast. So to say as contrast-induced nephropathy, the creatinine have to rise 48 hours after contrast. Another important and repeated MCQ. Expand press. What is PRES? Posterior reversible encephalopathy syndrome. The investigation of choice is MRI, not CT. They told in the quiz this CT was kept just to show in the posterior areas, occipital areas, you might see the blunting of the alkyl gyri.